Hello friends. Today in Mediastinum, we will be discussing the respiratory system examination performer, including general and systemic examinations. It's going to be a quick review where I have combined information from three clinical books, which is Ankapal, Mehta, and Hutchison. I'll be taking you to these books in between for references, which are highlighted, and I find them important for you to go through as well. Plus, I am going to discuss a combined proforma which I have made from these three books and will be adding information to that. And you can just print it out later on, practice your case taking on that, and try to memorize the proforma so that it comes out more naturally for you when you take in any respiratory case. Okay, so before starting, let me tell you that I'm not including history in this course. This is only going to be an examination proforma because this is more important every time we reach systemic examination, general examination, we start to lose our confidences and we just leave the case, which should not happen. We should go beyond taking history and also examine. Okay, and there are a few things of symptomatology which I wanted to cover from Harrison, but I realized that there is a very good video, explanatory video on YouTube already by Dr. Sanfinch on respiratory symptomatology. So I want you to refer that as well after you're done with this, or you can do it before this. Any which ways which suits you. Okay, so we'll start with the general examination. So like most of the systems, the general examination is going to be the same. The only thing is when you do this, you have to keep a holistic approach and also keep an approach from a respiratory system point of view. So there are a few things which are very common in all these systems whenever you take a general examination. You start with build, you start with nutrition. You look for the patient's overall build, you look for the nutrition of this patient to see for any chronic infection of disease. If you're suspecting tuberculosis, you might appear, the patient might appear completely wasted, thin, might have lost a lot of weight in the recent times. You can also think of an elderly patient who has had a long history of smoking or chronic bronchitis, you have to look out for cancer. So all of these will come under building nutrition. Besides that, the very basics, temperature, pulse, respiratory rate, and blood pressure. So in respiratory rate, you know that the normal respiratory rate is 16 to 10 beats respirations per minute, 16 to 20, and anything more than 20 makes it a dyspnea, anything less can make it a dyspnea, and then there are various causes for that, right? And the patterns of respiration we'll be discussing further in detail when we come towards systemic examination. But this is for the general case and BP. So BP, can you think of anything specific which you have to note in a respiratory case for BP? Okay, so I'll tell you one thing very specific is pulses paradoxes, which an examiner might ask you can relate the BP specific respiratory case, for example, chronic bronchitis or bronchial asthma. So what happens here? What is pulses paradoxes? So pulses paradoxes is nothing but what happens is it's an exaggeration of a normal phenomenon. Now, why do I say a normal phenomenon? See, whenever the heart receives blood, okay, during inspiration, what happens is the right side of the heart receives more blood and traps it towards the lungs because it has to oxygenate the air which is coming here, right? And so this is the right side of the heart trapping more blood and sending it to the lungs. So the left side of the heart has not enough blood to contribute to the systolic blood pressure. And so every time at inspiration, as a normal phenomena, the systolic blood pressure decreases by 10 millimeters of mercury. That is normal. Okay, this thing is normal. So what happens in pulses paradoxes? This decrease in BP is more than 10 millimeters of mercury. In such cases like chronic bronchitis, bronchial asthma, where there is a respiratory pathology, the lung parenchyma is involved. There is more trapping of blood, there is more fall in BP, and this is what is not normal, this is abnormal, which can sometimes relate to the severity of these cases and may reflect on the BP of the patient. Okay. Now, coming forward, besides that, we are going to look for the other things in this general examination, which is picking. And we are going to discuss how each can give a specific clue towards respiratory illnesses. So the first P is pallor, which is reflecting anemia, right? So what can anemia relate to a respiratory cause? What happens is anemia can happen if there is a direct blood loss. How can there be a direct blood loss? So there can be a direct blood loss if there is hemoptysis. Hemoptysis can be seen in cases of pulmonary tuberculosis. It can be seen in cases of lung tumors. So there is a direct blood loss, and if it's very, very significant, it can reflect in the patient with anemia, along with the patient's chronic malnutrition, which might be contributing it. So the malnutrition might lead to less protein intake, and less protein intake can reflect as anemia. So malnutrition can be a cause of pallor, and there is another cause, which is again because of excessive sputum production. Even if it's not just blood in sputum, it is simple sputum and loss of protein in this sputum for a very, very long time can also produce pallor. Okay. All right. So coming towards eye, the eye is for icterus. Icterus is nothing but the yellowish hue that we see on the skin and the mucous membranes, which will be also called as jaundice. Right. So where do you look for it? You look it in the lower palpebral conjunctiva, and then you can also look for it in the palms, in the soles. You can look for it in the vaginal mucous membranes as well. So do you think there can be a respiratory cause for icterus? Are you sure? So let me tell you how can icterus be related to respiratory system. So the very first cause, which causes a very significant icterus, is pulmonary infarction. Alright, so how can the pulmonary infarction take place? Suppose there is a pulmonary embolus or a very long-standing pulmonary infection causing thrombosis in the pulmonary vessels, which led to infarction of a part of a lobe, something. So what happens is this part of the lobe which gets infarcted contributes to significant anoxia. There's a lot of loss of oxygen. And already, because there is pulmonary infarction, the right side of the heart is also affected. It's not able to pump properly. And when it's not able to pump properly, there is a lot of regurgitation happening. The blood stays back and back towards the liver. So there is congestion plus the anoxia, which is contributing for a part of the liver to die. And that leads to centrilobular necrosis of the liver. And when that happens, you have icterus, you have jaundice. Okay, so pulmonary infarction is known to be a very significant cause of icterus. When you are as patient in the ICU and suddenly start feeling icterus, you have to look for these causes. All right. Besides that, what else can it be? So there are a few drugs which we use in respiratory system which can cause it. Yeah, they're related to tuberculosis. So I'm talking about HRZE. Which of these? So these three of them are very toxic to the liver, and more than the order could be Z more than H more than R. Okay, Zehar. So pyrazinamide, isoniazid, and rifampicin. These drugs are more likely to cause icterus. If the patient is on these drugs for a long time, we can suspect. Okay, and what else? Anything else? Yeah. If you have a liver tumor, lung tumor, and it goes as secondary to the liver. That means if there is metastasis and involvement of the biliary system leading to obstructive jaundice can also lead. So it's one of the other causes. Okay. Coming towards the next. C. C stands for what? C stands for clubbing. And clubbing is a very important topic in respiratory system examination. So it's very likely in UG examination, whenever you mention clubbing, they take you through the entire spectrum of questions towards clubbing. So let's discuss those as well. Okay. So very first thing is they ask you to define clubbing. So definition to be what? You say hmm, clubbing is a selective bulbous enlargement of the distal ends of the digits because of increased subungual soft tissue. So selective enlargement of the distal end of the digits because of what? Increase in subungual soft tissue. Okay, there's some deposition of the soft tissue which happens, and there are a few theories of why this happens. So let's just cover those theories first. Okay, theories which has been mentioned in alga price. I'm talking about those. Very first we call is neurogenic. Neurogenic theory says that because of vagus getting stimulated in respiratory system diseases, it leads to dilatation of the vessels and it causes clogging. The second one it says is humoral. Humoral, which is related to some hormones. So what are those hormones? Those hormones can be growth hormone, they can be prolactin, they can be PTH, they can be estrogen, they can be prostaglandins, and they can be bradykinin. So all of these hormones are somehow related, basically. The third one says it's because of ferritin. So there is a lot of ferritin accumulated, and that leads to, I'm sorry, so accumulated, it's rather decreased in the systemic circulation that causes dilatation of the arteriovascular anastomosis. Fourth thing is hypoxia. So as the lungs are involved, oxygenation is affected, oxygenation decreases, and it leads to opening of the deep AV fistulae, and these fistulae open, cause dilatation, increase of the subungual soft tissue. The fifth one, and the most accepted theory, they say, is the platelet-derived growth factor. So this factor somehow increases, and this increase in the factor is the most important cause which causes this vasodilation of the AV fistulae and other vessels, causing increase in the subungual soft tissue. So if you can remember, just remember vagus, remember some hormones, ferritin, decrease of strength, and the most important one being PTH. Okay. Okay. Now they talk to you about the angle. So the angle between the male bed and the males has a specific name called the Lovie-Bond angle. Lovie-Bond angle. And this Lovie bond angle has to be normally less than 160. But by any chance, if it increases to become more than 180 like this, it's called a clubbed finger. So that is what you look for when you ask the patient to show their fingers, the dorsum of the hands with the fingers projected, and you see for this. Okay, so if you're not able to see this directly, if you're not sure, then what do you say? You ask this patient to make this, right? You ask the patient to touch both of their index fingers together like this, and you want to look for this diamond-shaped space, which will normally be present if the angle was this one, 160. But the angle is more than 180, then this space gets obliterated, just like this patient's, right? This patient's space is not seen here because it has been gotten obliterated. And this particular sign is called what? It's called your Shamrod's sign, right? So Shamrod's sign present is an indication of presence of clubbing, no visible space. Then they ask you about what are the gradings of clubbing. So gradings of clubbing are four, four of them. The very first is fluctuation test positive. The second one is obliteration of the Lovie bonds angle, which you'll be able to see by making the shamrods. This one. Then there can be a parrot beak appearance because of increased curvature, or a complete box-shaped distal digit becoming a drumstick appearance. So both of these appearances come under grade 3. And grade 4 is something very specific, which is called your hypertrophic osteoarthropathy. What happens here is there is subperiosteum new bone formation, which makes your finger permanently enlarged. It's not soft tissue enlargement anymore, it has become a subperiosteal new bone formation. Okay, so this is the highest grade of clubbing which can happen in a very long standing present cause is there. Okay, so these are the four grades. And remember that there is a slight mistake in the grading which has been given with Algappan. So this is the corrected version of that. Okay? Fluctuation, obliteration, appearances, and hypertrophic osteoarthropathy. If you want, you can remember as FOAH. A is for appearances. So there are two appearances. O is for obliteration, F is for fluctuation, H is for HO. Okay. Anything else I wanted to mention? So clubbing के causes you have to remember. So there are very many causes which can keep on uh, enlisting. For example, in the lungs, there is bronchogenic cancers, metastatic lung cancer, anything which is causing a lot of infection like bronchitis, cystic fibrosis, abscesses, empyemas, ILDs, also sarcoidosis. In CVS, there can be cyanotic heart diseases. In GIT, there is Crohn's, ulcerative colitis, cirrhosis. So many causes are there. But there is one specific cause which you should never, never, ever mention in the causes of clubbing, and that is COPD, specifically chronic bronchitis. So chronic bronchitis is never a cause of clubbing, so never associate them together. Okay. So whatever you say, many things I told you, say cancer, it's called cystic fibrosis, emphysema. Uh, emphysema can sometimes cause, okay, but not chronic bronchitis. Okay. You have lung abscesses. In GI, you have all those IBDs, ulcerative colitis, um, other malignancies, liver cirrhosis, many causes, but never chronic bronchitis. This is all I wanted to know. Okay, so I think we're on clubbing, the basics. This is what you can never forget. The theory is the angle. The angle has to be less than 160, more than 180 is significant. Shamrock sign and the degrees. Alright. So anything else which is left here in general examinations, there are two more C's. Okay, three more things are left. One C is cyanosis. What is cyanosis? So that's the bluish hue that you see in the mucous membranes or the skin. And why do you see that? It's because the oxygenation of your blood is not enough. Okay, and so the deoxygenated hemoglobin is what carries that bluish hue. And when will that happen? So you can make sense of it. Whenever the lung is not able to function, a significant part of it is an acute onset, low function, acute, or sometimes even on a very long chronic case where the lungs have significantly lost their function, where the gas exchange membranes are no more, functional. That is when we see them. So, in very significant chronic bronchitis in the later stages, or even in a very acute pulmonary infarction of a large lobe, can also be that. And so, chronic bronchitis, the patients which we see will appear to us as blue bloaters. And we will notice this in a very first, you know, appearance of the patient. The patient walks to us, sits down, you notice slightly blue hair of patient. You'll also notice that the patient is breathing with his lips pursed, pursed lips. Why? Because he does not want his alveoli, his respiratory tracts to collapse. And to prevent that, he has to purse his lips so as to maintain a positive expiratory pressure. Okay, expiratory pressure, positive expiratory end pressure, so that these uh, terminal respiratory tracts will not collapse. And for that, he will be breathing like that. So you can notice these things in the first impression to find out what illness the patient may be suffering from. Alright. Coming towards L, L is for what? Lymphadenopathy. So any enlargement of the lymph nodes, which you'll have to look for. You look for those lymphadenopathy in the neck. So listen, all the stages wise, the level wise you check. If you don't know how to check, please go and read how to look for lymphadenopathy. I'll try to make one small video on that as well. So the important point here is the examiner might ask you that if there is a lymph node palpable, how do you know it is significant? Well, sometimes lymph nodes are just palpable in a healthy patient. Sometimes it's palpable in us as well. And then they slowly disappear. So how do you know it's significant? So significant lymph node in the neck is anything which is more than zero point 0.5 centimeters in diameter according to L and has to be formed in consistency. Now, if it is very hard and stone-like, it can be related to malignancy. If it is just matted and matted together, it can be a sign of tuberculosis. If it's very hard, craggy, stone-like, can be malignancy. All right, and there is something very important about the lymphatic drainage of the lungs. So I'll just mention, which I've been mentioning it alcohol there. So I make these two sides of the lungs. This is right and this is left. So the left upper lobe has to be a different entity, and the rest all is together. So all of the right side of the right lung and the left lower lobe goes to which side? Goes to the right supraclavicular lymphatic nodes. यहाँ पे. So right supraclavicular lymphatic nodes में इन सब का drainage होता है. But the only part which is the left upper lobe goes to the left supraclavicular lymphatic node, which has a specific name. What do we call it? Yeah, it's called the Warshaw's. 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 Warshaw's, if we talk it in Hindi English, Indian English, and for cows, which is the actual word which we say. For cows lymph nodes is where the left upper lobe goes. And some part of the GI also goes here because of its retrograde permeation. So that is what is possible. Okay. So that is about the lymphatic drainage. Besides that, the parietal pleura, the pleura which is on the outside lining the muscular musculoskeletal part, and that goes to the axillary lymph nodes. Okay, so you may also check for the axillary lymph nodes. Axillary lymph nodes can be checked for and the supraclavicular lymph nodes besides the lymph nodes of the neck. Alright. Now coming towards E, E is for pedal edema or any other edema which you can notice. So can you think of any respiratory cause which can lead to edema? Yeah, we talked about it, right? See, if there is involvement of the right lung, I'm sorry, the lung for a very long time, then what happens? The right side of the heart gets affected. The right side of the heart gets affected when its function goes down. There is a right-sided heart failure. What do we call it? Core pulmonary. Why? Because the lung was the responsible cause for causing the heart to fail, right? That kind of a heart failure is called core pulmonary. So when the right side of the heart fails, what it leads to? It leads to congestion. It leads to congestion downside, and all that congestion will lead to what? Pedal edema. And there is one more cause. If the patient has been producing sputum for a very, very long time, cough and sputum production is in chronic bronchitis, and when there is loss of a lot of protein, loss of protein via sputum, that leads to edema as well. So anything which is related to chronic malnutrition, loss of protein in sputum can lead to pedal edema. Alright. Um, in the general examination of our respiratory system, we also have to mention the stigmata of tuberculosis because we have to note for signs of other respiratory system diseases which are common. So this has been mentioned in Mehta, and I want you all to remember these five signs which are very basic. uh, they talk about flexilar conjunctivitis in the eyes. Then you come towards the neck and look for scars and sinuses. Then you go towards the spermatic cord and check for the thickening. Then the legs, the dorsum of the legs, you look for these red marks, these red enlargements, which are called erythema nodosum. And the TB of the skin, otherwise, which is cutis vulgaris, scrophulodema, which you'll learn in detail in your dermatology. But these are the few signs which you have to look for as peripheral signs of tuberculosis. And even if they're not there, you still have to mention towards the end of your general examination that there are no peripheral stigmata of tuberculosis noted in this patient. Okay? By the way, what is flexular conjunctivitis? So in the eyes, in the inner corner, we see enlargement and reddening. In the inner corner, there is this flectin which is formed and reddening of the eye suggestive of some allergic reaction to tubercular proteins, which has been mentioned in ophthalmology. You learn it. But this is what you have to look for in tuberculosis as well. Okay, that's okay. Now, as we're done with the general examination, we come towards the systemic examination, which includes our inspection, our palpation, percussion, and auscultation. Right. So before we go towards the lower respiratory tract, which we are always in a hurry to go to, we never have to forget that there is also one important part in respiratory. There's the upper respiratory tract, which has to be mentioned before the lower respiratory in inspection. So we look for the nose, we look for the symmetry of the nasal septum, we look for there any obstruction is present or not. We look for the oral cavity, the presence of any staining of the teeth for marks of tobacco consumption. If the patient says that they do not, and you suspect that they do, you'll easily find it in their oral cavity. Then in the oropharynx, you have to look for the tonsils, you have to look for the adenoids if they're enlarged, sinuses, you check for sinus tenderness, if there are complaints with respect to those as well. So the upper respiratory tract has to be mentioned fully. Even if in the nose we might notice polyps, which are signs of allergic pulmonary bronchopulmonary aspergillosis, allergic asthma, Pechinus granulomatosis, cystic fibrosis. So all of these findings you can notice in the upper respiratory tract and mention. Coming towards the lower respiratory tract. Now, this is the entire part which is a lot intimidating to a lot of you because you don't know where to look for the diameters, how to look for symmetry, how to measure the expansions, what are premises, what is tactile premises, what are vocal premises, what all sides on the chest wall have to focus, where you don't have to focus, how many parts of the chest wall can be divided into, and what if they suddenly ask you about the lobes of the lung and where do they lie? So I want you to be thorough with all of this. Before jumping into this, I want you all to know the surface anatomy of the lobes of the lung. So for that, we'll go back and see it first. Okay. So remember that the lungs, on the right side, we have three lobes, right? On the left side, since we also have the heart, the lobes have been conveniently divided only into two. So if you want to know that where exactly is your upper lobe, where is the middle lobe, and where is the lower lobe, there are few surface markings. Now what are surface markings? We used to study in first year surface anatomy पढ़ते थे. तो हम कुछ ribs से, कुछ spine से, कुछ sternum से relate करके we used to divide the lung, right? So यहाँ पे what we do is the second thoracic spine on the back side. This is the front view, right? So the anterior view है, but we're talking about the T2 spine, which will be on the back side. So from the back side, you create a line, okay? And you connect this line anteriorly, where at the sixth costochondral junction, okay? The sixth costochondral junction on the anterior side. And where is this cutting? This line is cutting in the fifth rib, in the mid-axillary line. So this is the mid-axillary line. The fifth rib is getting cut here, but it's starting from the T2 spine and it's coming and ending on the costochondral junction 6 one. So this entire line which we have made is actually our major fissure, also called as the oblique fissure. This is the major fissure, major of the oblique fissure, which is dividing what? It is dividing the upper lobe from the lower lobe. So upper and lower has been divided by this major fissure. Now there is another line which will go again from the mid-axillary line, in the fifth rib which we have made. We are going to carry this line anteriorly where? To the fourth costochondral junction. So fourth costochondral junction, this one, if you make a line here anteriorly, this has become your horizontal or the minor fissure. So this is your horizontal or the minor fissure, which is dividing again your upper lobe from the middle lobe. Now, as you see on the left side, there is no horizontal minor fissure, there is only one major fissure. This one major fissure again is coming from the T2 spine, it's crossing the fifth rib in the mid-axillary line and coming anteriorly to end at the sixth costochondral junction. Sixth costochondral junction. So this entire fissure is the major fissure or the oblique fissure, again dividing the left lung into the upper lobe and the lower lobe. Okay. So what do you understand? Now, if you see a person from the front, what are the major lobes you'll be able to see? The major lobes which you are able to see here are the upper lobe, the middle lobe. The upper lobe is somewhere where you have the supraclavicular area, the clavicular area, the infraclavicular area, and the mammary area is nothing but your middle lobe. Okay. And there is a little portion of the lower lobe visible on the anterior side. It's very little. It's not major. So if you auscultate from the anterior side, what are you hearing? You're hearing in the middle lobe and the upper lobe, but very little of the lower lobe, right? Now just turn the patient. When you turn the patient and you look at this patient from the posterior side, what are you able to see? The upper lobe, only a very little portion, okay, very little portion, and majority of the body surface here is going to be your lower lobe. So when you auscultate, the suprascapular area is mainly the upper lobe. When you auscultate the scapula, the interscapula, the lower scapula, what is it? It's mainly your lower lobe and the bronchi. All right, you want to see the patient now? See the patient and identify how the lobes will look. So if this is your patient, hmm, hmm, tell me what is your, here should be your upper lobe. Okay, this area should be your upper lobe, and the majority of the mammary area this way should be what? Lower lobe. No, it should be the middle lobe, right? This is the middle lobe. And this little portion here, you can say, is the lower lobe. But for all practical purposes, when you want to hear to the lower lobe, you make this patient like this, you make this patient like this, and then you auscultate here in the scapular area, the infrascapular area. The suprascapular will be mainly the upper lobe. You get that? Okay. Alright, so let's come back to our proforma. Hmm? So here, the shape of the chest is the very first thing. When you start with the lower respiratory tract inspection, there are three or four things which you have to remember. So besides understanding this proforma, we also have to effort, make an effort to remember the proforma. So we are starting to understand as well as try for a few tricks to remember. Okay, so very few things. Shape hai, movements hai, mediastinum hai, and miscellaneous things hai. So let's start with the shape. The shape mein, what do you want to look for? The first things are the diameters. Then you look for the symmetry, both the sides. Then you look for the intercostal spaces, hollowness or bulging of that, any deformities, any spinal deformities, any chest deformities. So what exactly? Let's go to Mehta and understand. Okay. So what is the shape of the chest? Shape of the chest normally is bilaterally symmetrical. Obviously, it has to be symmetrical. And its anterior-posterior diameter is lesser than the transverse diameter. So what is the ratio? It is 5:7. Okay. So there is 5:7 is the ratio. When you look for the subcostal angle between the two ribs, the lower border of the ribs has to be acute, has to be 70 degrees, and in females it's slightly broader. Okay. Now, abnormal shapes of the chest. So it can be pigeon breast or keeled chest or pectus carinatum. So what happens is, as you know, the bones of crickets are very, very weak, fragile. They get bent easily. So the legs are also like these bow legs. So even the sternum gets bowed like that. So when the sternum becomes like a bow, it penetrates inside in the lower part. So when it penetrates inside in the lower part, the chest looks like this on the lateral view. The sternum is bowed like this. The chest looks like this. There is a hollowness under the sternum. And this hollowness under the sternum makes it look like a pigeon breast. Okay. Besides that, the costochondral junction will be bead-like enlargement called rachitic rosary. The rachitic rosary is not painful, but scorbutic rosary is painful. Remember? And there is a transverse groove which passes outwards from the zippy sternum to the mixed axillary line, which is called as a Harrison's sulcus. Also a feature of chest of a rickets patient. Coming towards funnel chest, or cobbler's chest, or pectus excavatum. So there's a depression in the lower part of the sternum, which may be congenital, following rickets or occupational deformities, also in cobblers who keep sitting in that posture for a very, very long time. And that leads to the normal cardiac shadow shifting a little bit, appearing enlarged, and that is called a form Fritz heart. Okay, so funnel chest हो गया, rickets chest हो गया. Chest has to be symmetrical. AP transverse ratio has to be 5:1, 5:7. But are you going to mention this ratio in inspection? No. You're just going to say that the anteroposterior diameter looks normal. The anteroposterior diameter is lesser than the transverse diameter. The chest overall looks symmetrical. There is no abnormality of the shape of the chest. This is what you're mentioning. Why not mention the ratio right now? Because you're not measured it, right? Can you just inspect from your eyes and say that this is 5:7? No, you can't. You can only give your approximations, and approximations are never given in digits. So you have to just say that this looks normal. Now, barrel-shaped chest, we know it is seen in COPD, yeah, because of expansion of the chest. And in barrel-shaped chest, the ratio almost looks like 1:1. It's almost same. Anterior-posterior and transverse becomes same. So that is what you have to look for. It is COPD. And then, as we talked about spinal deformities, chest wall deformities. So is the spine abnormally curved? Okay. Is the spine abnormally deviated? Or the ribs abnormally curved, abnormally deviated, any scorbutic rosary, any rachitic rosary? All of that has to be mentioned in spinal and chest wall deformities. Bulging of the intercostal spaces, as you can see in patients who have infusion, who have pneumothorax, there is trapping of air, a lot of it. If there is any necessitance, an infection inside uh, the pleura communicating with the chest wall, if there is cardiomegaly or any scoliosis, which makes the intercostal spaces to become abnormal and localizedly bulged. So all of that has to be looked for. Depression or flattening, where can you see it? If there is fibrosis, if there is collapse of the lung, if there is muscle wasting as in patients with poliomyelitis or congenital absence of pectoralis major, right? Poland syndrome, if you remember, and all of that. Flat chest is also called as pythinoid chest, and that happens because of chronic nasal obstruction because of adenoid lymphoid hypertrophy, bilateral TB, childhood rickets, sometimes leads to flat chest. Okay, so that is what you have to mention. So are we done with this? We talked about the entire part of the shape of the chest. We mentioned the diameters. We talked about the symmetry, if everything was normal, if the inferior angular, the scapula, the spinoscapular distance. We just have to see if they look abnormal and you say, okay, it looks symmetrical. There is no following or bulging of the intercostal spaces. There are no significant noticeable chest wall deformities. There are no significant spinal deformities noticed. Okay. Coming towards movements. So movements, the very first thing you mention is the weight, the rhythm of the movement, the character or the pattern of the movement, as you know, we call abdominothoracic, thoracoabdominal, right? Abdominothoracic, thoracoabdominal. This one is normal in males because in them, abdominal movements are more significant. But in females, thoracic movements are more significant. So that is why thoracoabdominal in females. But if there is only abdominal, there is no combination, it becomes only abdominal, it becomes only thoracic, then that is a problem. Because only abdominal means the chest wall muscles or the pleura is not functioning properly, and that is why only abdomen is responsible for inflating the lungs. And only thoracic means the abdominal muscles, the diaphragm is not able to function properly, or there is ascites and is causing problem to function. So that is why only thoracic is predominating. So those movements have to be mentioned, and if that is abnormal. Otherwise, a combination is normal. Okay. Then we talk about the symmetry of movement, any signs of labored breathing which we look for, like accessory muscles of respiration, the alae nasi, if they are functioning, you should mention nasal flaring, there's noisy breathing, there are retractions, if there is breathing with opened mouth or breathing with pursed lip, which we talked about in COPD, right? So all of that has to be mentioned. Let's go back and just check the book again. Hmm. So here, respiratory rate, we know the normal rate has to be 16 to 20 beats per minute, and anything which is more than that is abnormal. Okay. And remember that, as you know, our respiratory rate is up to 20, and our heart rate goes up from 90 to 100, 60 to 100 beats per minute. So if I take it is 80, it is 1 is to 4 ratio. So this ratio has to be maintained. Anytime the respiratory rate increases, the ratio will also alter. So when do we look for tachypnea? Respiratory rate, when we'll be looking for, there is normally an excitement, somebody is exerted, just walked a lot, climbed a few flight of stairs and just came into your OPD, you might notice them exerting, but that will not stay forever. Otherwise, in fevers, in pneumonias, in hypoxias, in acidosis, in anemias, and poisoning, etc., you'll find them having a high respiratory rate. Whereas bradypnea or decreased respiratory rate is seen if the patient has opioid poisoning or the patient has a brain tumor. So anything affecting the respiratory centers, not allowing them to regulate the rate properly, might affect the respiratory rate, producing bradypnea. All right, so we're done with the rate. Now we come towards the pattern or the rhythm. Okay, so normal respiration has a very regular rhythm where the inspiration is slightly longer than the expiration. And why is it so? Because inspiration is an active process where the muscles are actually functioning to allow the parietal pleura to separate and allow the pressures to generate and allow the respiratory system to inflate. This is an active process. But expiration, on the other hand, is passive, and its passivity is contributed by the elasticity of the lung parenchyma, the elastic recoil of the terminal respiratory portions of the respiratory tract, which allows the air to be recoiled back through the process, through the tract. And that is why this is slightly shorter because it happens passively. So because this is passive, the expiration is slightly shorter than the inspiration, but it has to be regular. So when there is inspiration, there is expiration, inspiration, and expiration has to be very, very regular. But if by any chance the rhythm gets altered, we notice and we have to name those rhythms. And those rhythms have been named accordingly. So we have Stein-Stokes respiration. What is Stein-Stokes respiration? So there is a rhythmic alteration of apnea and hyperapnea because of anoxemia. How does it look like? So there is a portion where there is a lot of hyperapnea, the increased depth and rate of respiration. I'm sorry. So initially there is increased rate and depth of respiration. Then suddenly there is a pause and there is hypopnea. Again there is increased rate and depth of respiration and there is a pause. So why does that happen? Now, suppose the patient is uremic, okay, or is in deep sleep, or there is some poisoning affecting the brainstem centers, or there is left ventricular failure affecting the oxygenations and the blood supply to the respiratory center. So what happens? The respiratory centers are not getting enough signals to generate uh, respiratory signals. So what happens? There is a period of hypopnea where there are no enough respiratory centers signaling happening for respiration. Now what happens? Because of this hypopnea, there is accumulation of CO2. And we know CO2 is a very potent stimulator of the respiratory center. So whenever there is hypercapnia, the respiratory center, despite having its initial uh, decrease in activity, CO2 is able to slightly stimulate it to make it function again. And that functioning again leads to increased rate and depth of respiration, which finally leads to washout of CO2 and development of oxygen. As soon as the CO2 washouts, there's no more stimulation to the respiratory center. It goes back into its sleep phase. And when it goes back into sleep phase, there is hypopnea again. So this hyperapnea, hypopnea, hyperapnea, hypopnea keeps on altering and leading to this kind stroke respiration. So if you remember, you can remember as a crescendo decrescendo. That is what I remember as that. Crescendo decrescendo मतलब कुछ बढ़ना कुछ कम होना. That kind of a pattern is called as time stroke and is associated whenever the respiratory center is depressed. So remember of uremia, of deep sleep, of poisoning, and left ventricular failure. Okay. What is the next pattern? The next pattern is called as Kussmaul's. So Kussmaul's, I'm sure everybody of you knows. It is a very deep and rapid respiration. So both rate and depth, sort of an air hunger pattern. And that is seen in ketoacidosis, in alcoholism, in starvation keto, and in uremia. So you see the rate is also increased, the depth is also increased, and that is called as Kussmaul's crazy respiration, is what I remember it as. Coming towards Biot's. So Biot's is something which is chaotic. Biotic, chaotic. Can you remember that way? Something very, very irregular. You cannot make out. Like if there is increase and then pause, then again increase, 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 pause. There is no pattern at all. It's completely chaotic. And that is called as biotic, irregularly irregular, seen in patients whenever there is a brainstem meningitis or increased intracranial pressure. So meningitis and raised pressure are two causes of BOS, respiration. So from B, I remember as brainstem meningitis, and B, say pressure, BP. Okay, these are the two causes which you can never ever forget of BOS. Coming towards other causes of obstruction which you may notice is stridor and wheezing. They're not patterns, but they're rather the voices which a patient might make during inspiration because of obstruction in the upper respiratory airway or in the lower airways like bronchi and bronchioles. Alright. So another thing is stutter. So stutter is because of very obstruction in the higher upper airways, where in the nose and in the throat, when there is an obstruction, we call this as a stutter. So all of that, adenoids, if they're enlarged, the adenoids enlargement, if there is enlargement of tonsils in the throat, sometimes can cause that kind of obstruction. It's very severe. Okay, so we've understood the rate, we've understood the rhythm. The type of breathing, which I've already mentioned, that in males we have abdominothoracic, in females we have thoracoabdominal. But I think I've made a problem here. Thoracoabdominal, like this in previous thoracoabdominal. So this is normal, okay? But what happens if there is only thoracic movements? I told you, it means the abdominal movements are not happening properly. And why they're not happening properly? Because the diaphragm is not able to function, or there is peritonitis and ascites, which is not allowing any movements in the abdomen. This is abnormal. Abdominal movements predominantly, that means there is no thoracic movement at all. Why can it happen? Because there is pleurisy or there is collapse of the lungs, right? That gives you a hint about the underlying cause. So type of breathing is also done. Now movements of the chest. Okay. So what happens normally, because both your lungs are normally totally equal. Okay. So practical purposes, when they inflate, they have to create similar expansions on both the sides of the chest. But if they are not, that means there is some problem on one side of the chest which is not inflating properly. So unilateral diminished movements might happen, or bilateral diminished movements might happen. But what you need to notice is the movements of the chest are able to expand the chest totally by 5 to 8 centimeters. How much? 5 to 8 centimeters. So if you put a tape and measure, by the way, we're talking about inspection right now. So there is no purpose of putting a tape on the chest. You're just seeing correlations. You have to just observe. But when I'm talking about putting a tape and measuring, this expansion between the two ends of the tape has to be how much? 5 to 8 centimeters. And anything like severe emphysema with the chest, where the lungs are already severely inflated and there is air trapping, the expansion can go up to less than 1 centimeter, which is very, very severe, right? So these are the measurements of chest expansion which you have to look for. Now we're talking about just movements, so we notice, we just see and we say. Lateral diminished movements. What are the causes? Obstruction to the main bronchus, or there is consolidation of one side of the lung, or there is fibrosis of the lung, or a massive collapse of one side of the lung, or there is a hydropneumothorax over an entire lung, or a big pleural effusion affecting the inflation of the lung. Bilaterally, it is because of emphysema, as I told you, bilateral collapse, consolidation, fibrosis, bronchial asthma. Again, where both the sides are reversibly obstructed because of bronchial hyperreactivity. Okay. And while you're noticing the movements of the chest, you also have to look for any exertion that the patient is having while trying to inflate his chest, like the involvement of accessory muscles of respiration. You look for the ali nasal on the nose, the sides of the nose, any flaring happening or not. You look for the sternocleidomastoid muscles, which should not normally be required. You look for the abdominal movements. However, in any condition that causes respiratory embarrassment, they are required to assist breathing and therefore becomes prominent. And this prominent involvement of these muscles has to be looked for. Okay. And then the media sign. So as we have done the inspection of the respiratory movement by looking for the rate, we have looked for the rhythm, the character, the pattern. What were the patterns? Kind strokes, which was crescendo, decrescendo, Kussmaul's, which was this crazy, Dior's, which is completely chaotic, right? All of these abnormal patterns we have looked for. Ataxic pattern, by the way, can be looked for if the brainstem is involved and medulla is involved, so there is complete loss of symmetry. It is called as an ataxic pattern as well. Okay. Then there is symmetry of enlargement. So just look for if overall if it is looking normally enlarging on both the sides. That is what you look for. Signs of labored breathing by accessory muscles of respiration getting involved. Any obstruction by presence of noisy breathing. What were those called? Wheezing, stridor, stutter at the level of the nose and the throat, stridor at the level of the vocal cords, and wheezing at the level of the lower airways. Right. Then we look for retractions, anything like open mouth, anything like lip breathing. That is respiratory movements. Mediastinum. So mediastinum is basically, we have to look for the symmetry where the bronchus divides and goes into both the sides of the lungs. The trachea has to be central. Anything which is pulling the trachea, the bronchi on one side, affecting this lung or maybe that lung, will reflect in the position of the trachea. And that is what we have to look for. So we look for two things. One is the trail sign and the other is the apex impulse. This entire portion is called a mediastinum, the central part. So you have to look for the central part being in the center or getting deviated. So trail sign is what? When you normally look at the neck of a patient, okay, you see the trachea slightly bulging, hmm, and you see this sternum. There's a slight depression here in the sternum, suprasternal depression. And there are two muscles attached here. This is sternocleidomastoid clavicular heads, which are sternal heads are attached. Now, what happens if the trachea was deviated slightly in this side? The pretracheal fascia lying or the pre-sternocleidomastoid fascia is lying here on the sternocleidomastoid muscle slightly gets relaxed and this head becomes prominent. This head becomes prominent than this one because this has been pushed by the trachea. And any abnormal prominence of the sternocleidomastoid muscle has to be looked for, and that is what we call the trail sign. The other thing is the apex impulse. So, what is apex impulse? It is the lowermost and the outermost definitive cardiac impulse, which we see because the cardiac beating. There's an impulse seen on the chest wall of the patient that's thin enough to let us see. So, by any chance, if this central portion, the mediastinum, is deflected on any of the side, the heart will be deflected. And if the heart is deflected, the cardiac impulse will not be in the normal position. So, that is what we have to look for. Where is the heart normally? In the left fifth intercostal space, half the centimeters medial to the mid-clavicular line. This is where it has to be normally. But if it is maybe in the sixth intercostal space or more than half a centimeters medial to the mid-clavicular line, suggestive of the mediastinum being deflected towards the left side. So that is about the mediastinum. And miscellaneous things like scars of drainage, maybe there are some sinuses of empyema necessitans. What is empyema? Empyema is a pleural infection, the pleural space infection which is communicating with the subcutaneous plane. So some pleural space infection which is now communicating with the subcutaneous plane, which might appear as a bulging of the intercostal space, and finally this infection finds a way out and becomes a sinus. That is what you have to look for. You have to look for dilated veins, involvement of the veins getting obstructed, like the SVC obstruction, as might happen in a Pancoast tumor, or a shiny red skin, again suggestive of an infected empyema, hepatic amoebiasis. So all of these are the miscellaneous things which you have to look for. Okay, so till now, what have we seen? We have seen the inspection, the shape of the chest, and all the points which we have to mention under the shape, the movements of the chest, and all the points which we have to mention in the movement, the mediastinum, two important points of the mediastinum, and miscellaneous points. Coming towards palpation.